Depression is a highly prevalent problem in patients that we as PTAs will be seeing. That is, those with chronic pain and/or disability. Research suggests that those suffering have a poor response to the therapy provided by those in our line of work. Given the significant numbers, it has been brought up that we as PTs and PTAs should be screening patients for symptoms of depression. However, unclear guidelines and procedures have left this initiative stuck in the mud. Either a PT will continue treatment as usual or refer a patient to a specialist, which is not always the most viable option. It has been shown that in some patients, symptoms of depression can improve over the course of physical therapy. This study wanted to focus on the variables most likely to determine whether or not a patient would see these results. If successful in identifying these traits, a clinician could make a better choice for their patient on which path to send them down, PT or specialist, based on this research. Multiple verified tests and scales were used in this study to collect reliable data on pain, symptoms of depression, and the patient's self-efficacy. Each test or scale was numerical and therefore objective data of a quantitative variety. 106 patients with both work-related musculoskeletal injuries and symptoms of depression were given 7 weeks of PT and were evaluated 1 year out over the phone. Once this data was collected, it was analyzed through a series of programs that separated and calculated the various types of information that the researchers wanted to examine and compare. The most significant separation was that of non-responders and responders. Responders were classified as those who at the time of the mid-treatment assessment showed resolved depressive symptoms, being defined by a BDI score of less than 14, or who at the end of treatment exhibited no signs of depression. This accounted for 43 of the 106 participants analyzed. Those who remained with depressive symptoms at treatment completion were deemed non-responders. It was found that responders not only had initially lower levels of depressive symptoms, but also showed sustained reductions in these symptoms throughout treatment. Non-responders had initially higher levels with less reduction of symptoms through the course of treatment. Responders were also more likely to return to work with less reported pain than non-responders when assessed at the 1-year follow-up interview. Results also revealed that patients who did not see a decrease in depressive symptoms by mid-treatment were more likely to be non-responders. Interestingly, it was determined that a combined cut score, created from the data of both the pre-treatment BDI score and pain catastrophizing score, was a unique predictor of responder status, and therefore most accurate in determining a response to treatment. Overall, it was found that while a portion of patients can resolve their depression over the course of physical therapy treatment, there are 2 indicators that make this an unlikely outcome. Patients who have high pain catastrophizing and BDI scores before treatment, along with a lack of improvement in their symptoms of depression or pain self-efficacy by mid-treatment or sooner, are not likely to see the wanted regression of depression. So if a patient is initially evaluated to have mild to moderate symptoms of depression coupled with higher levels of pain catastrophizing, referral to a specialist might be the best way to go. That is not to say that PT couldn't potentially help in tandem or resolve the problem completely, especially if care is very personally modified for the patient in question. However, if a patient shows any suicidal intention, which is 2 times more likely when suffering from pain and depressive symptoms combined, they should immediately be referred to a specialist. It is also important to remember that attitude, support, empathy, and treatment expectations can have a big impact on the success or failure of a response. In fact, when PTs added this dimension of alliance to their treatment, their patients experienced an additional 51% reduction in their symptoms. Now, this study is not without its flaws, and it has been found in previous studies that some patients can actually experience worsening symptoms over the course of a physical therapy treatment. But overall, the data does at least seem linked to accurate predictors of whether or not a patient will respond to PT treatment. The researchers themselves pointed out that this study could be completed again with a larger sample size, a control group, inclusion of extrinsic factors when processing data, and less variance of treatment types and attendance to gain more applicable results. However, with about 40% of the patients in this study having resolved depressive symptoms, I think it's fair to say that in at least some cases, physical therapy treatment can be an effective or appropriate route for a patient in pain to take, even if they struggle with depression. Thank you all for listening to my presentation.